So what I asked the panel to do before they came on was to think about answering this question about what are the opportunities in the short term for technology to reduce the burden on health services, and to spend just no more than a couple of minutes sort of setting out their stall on that. So I think I will turn to Teus. And if you could keep your remarks short. And also, one of the things I think is really interesting at these meetings is if you have any colour or examples. As a journalist, I kind of want you to show me, not tell me. I want the specific rather than the abstract, if you're able to do that. Anyway, Teus.
So I think what we can do in healthcare, and I think it relates to what was discussed this morning, because we were talking about professionals and we were talking about patients and making sure that we get a new workflow into that. But what we have to realize is that healthcare is about one person or people asking professional other people for their help. And I think what we can do in the next couple of years is actually we can design technology that not supports either of them, but it supports that process of people helping others gaining or staying healthy. And it doesn't matter, I think, whether that's prevention, because we need more effective prevention, but we also need more efficient delivery of treatment. So I think in that sense, sticking towards that and making sure that a patient is better able to understand what the doctor and nurses are doing, but also a doctor and a nurse is working better together to share with their patients what they need. I mean, I think that's the biggest challenge, but also a challenge that's fixable in healthcare.
The patient journey, right?
So the patient journey, yeah, but included with the professional help, because I think that's often missing in that picture.
Okay, Jim, your thoughts?
So short term, I think we need to use what we've got. We've spent a huge amount on digital health technologies in the NHS and, of course, in other countries, and we need to take advantage of the installed user base. I'm from Manchester. Thank you. And we, like other ICBs in England, have got shared care records. What we have been doing is developing shared care plans to start breaking down the silos. So instead of your GP contributing to a health record and a secondary care team and a community team and a hospice team, we, like London, have built end-of-life care planning that is a multi-professional document. Anyone can see this, anyone can access it, and anyone can contribute to it. This is care around the patient using what we've got. And we can see from health economic analyses, getting end-of-life care planning right releases a huge amount of time and money to the health system. So I think short-term, use the two tools we've got and build them out.
Okay, Anca.
Thank you. You're a straight shooter, Natasha.
I certainly am.
I definitely respect that. So I'm here to mitigate on behalf of the AI. I know we're always questioning the power and also the risks and challenges that it poses. So I would say, first and foremost, where the opportunity lays these days is in AI and predictive analytics. And this is something we're thoroughly working on at the WHO. And what we're looking into is how we can use not just the real-time data that we're able to extract in health services, from health services and in health systems, but also secondary health data that is literally just lying there for years, and it's structured in silos and it's difficult to harvest.
Sorry, what's secondary?
Secondary health data.
What is that?
So what we're looking into, it's not just electronic health records that are not interconnected between primary care and secondary, tertiary care in some health systems, for example, but we're also talking about indicators and other metrics that are being reported on a daily basis from health services. Now trying to flip a bit the coin from a health system perspective to the health service perspective at the point of care, right? So we're looking at staff ratio, we're looking at turnover, we're looking at data that could be able to predict the crisis in a healthcare setting at the point of care before it happens, but it's just laying around and it has not been harvested so far. And We have a couple of projects going on. Some of them I'm able to speak about, some others not yet, as they are in the pipeline, and something exciting is coming up.
Oh, you can't tease me like that. Oh, come on.
Please stay tuned.
Clue.
Talking about reducing clinician burnout, for example,
Right.
in secondary and tertiary care,
Okay.
by using these kind of secondary data in a federated model.
Okay.
So to build on top of that, and to answer your earlier question, I would also say another thing that would take the burden off the healthcare services and build on the digitalization rather than just adding an app to a hospital, which wouldn't do much, is creating interconnected and interoperable systems. And by that, I'm talking about breaking silos and have interconnected data that is able to be not just carried in the pocket, which I would love to have. And coming from Switzerland, just flew in yesterday, I have to say honestly, I don't have an electronic health record, not by choice, just because it's not provided yet. But talking about as a patient having your data in your pocket and then being able to go through the whole patient journey in a seamless manner.
All right. That's brilliant. Great introduction. And Estia, you please, your 2 minutes on opportunities.
For sure. I think the key piece for us is access. So there are lots of ways in which technology can augment the pathways that we already know are great. And so one example of a company we've backed in this space is a company called Flock Health that is digitizing physiotherapy from the GP all the way down to community care and secondary care. One piece that sticks with me that the founder always says is, at the moment, you interact with the NHS, you go to a physio appointment, you're given slots between 9 a.m. and 5 p.m. And for a lot of people, that access is just not possible if you're working multiple jobs, if you're a carer. And so I think the short-term opportunity is really in how can technology increase access to what we know already works. And then, looking forward, I think there's a lot of opportunity for technology to innovate and actually improve the standard of care. But I think that the core thing for now in the short term is just what are we doing right and how can technology help more people access the standard of care?
And Chris.
Yes. Okay. Well, thank you. Well, look, the title of this panel is "How Can Technology Reduce the Burden on Health Services?" And I think the fundamental starting point is, where does that burden come from? And there are two things at play here. One is capacity and the other is demand. And you can have low demand and high capacity and vice versa. And I think the big issue here that's happening in every country in the world right the way across the board is that people are getting older, they're getting more chronic disease, and they're having greater expectation. And so demand is going up, but capacity cannot keep in touch with that. It's not possible. There's not, even if there was the financial resources, there's not the other sorts of healthcare resources we heard today about human resource side of things. So the question is, how do you square that? And for me, and the area that we work in is very, very simple. That's about going out to the citizens, into the population, into the public. That's where the solution here is to have the greatest impact. And if we look at other industries that have really used the power of technology, they are the industries that have gone out to citizens, whether it be through banking, there's travel, there's just so many numerous examples of that. And when I interact with those industries, I'm interacting all the time in terms of if I'm with the organisation sitting in an office or on a flight or whatever, they also have me when I'm not, whether I'm online checking in or whatever it is, to use some examples. The healthcare system is completely different. When we become sick, we go into the healthcare system, they patch us up, and we go back out into the real world. With 365 days of the year in the real world, with low levels of agency, and utilising a healthcare system when things go wrong. And that is not a great balance in terms of burden with the supply and demand.
Okay, so what we're going to do now is I am going to ask you to cast your mind forward a little bit about the opportunities that you see ahead, perhaps in the medium term. I'm thinking 3 to 5 years. And what I'd like you to do is think about that world you would like or you envisage in 3 to 5 years, and what the impediments are to getting to that ideal world. And I'm going to give you one wish, and you're allowed to wish away one of those impediments, and so that we can basically see what you think is the most important. And I'm going to ask you again to try and restrict your remarks to 2 or 3 minutes, so we all kind of get a flavour of what's going on. Who wants to go first? I don't necessarily have to start with you, Teus. Do you want to start first?
Sure.
Okay, fine. We'll go down the line.
So I think, and it also relates to Jim's comment, I don't think the technology is good enough at the moment. And I think what basically is the basic limitation is that the technology cannot work together. It cannot work together with other systems. So systems have a hard time working with other systems, and they have a hard time serving at least in healthcare, to be up to the level of an iPhone or an Android, to be serving it to the humans. And basically what I would wish, I think if we can find a way where we can break down these things and have systems work together, then you can really build a system where everybody gets what they need. Because that's the problem in healthcare. In a bank, you go to the bank. In healthcare, you go to the professional. And I think that's what I said in the earlier comment. It's about that one person helping the other, or a bigger team of people helping the other. But they have different needs, and they all need to be met. And we really need to get rid of the monoliths, which are really the impediment for any innovation. And we really need to get systems that work together, so innovation like that was dreamed of can actually happen.
Jim, when you reply, I mean, I'm also thinking about the conversation we had downstairs, and you were kind of talking about realising the gains of digitisation in the NHS and how difficult it was to kind of get the value back. I mean, would you say that that is one of the biggest impediments?
It's a huge challenge. When we think about technology, and if we think about problems with technology, people will often talk about technical debt. So compromises made during the design of a system which cause long-term problems. You can get technical debt when you write software, and you can get technical debt when you put bits of your systems together. What we fail to recognise a lot is that we also carry process debt. So clinicians have got ways of doing things, right? We're fairly obstinate. We've got a former cardiac surgeon. So when we have fixed ways of doing things and we ask people to change to adapt to the technology for no good reason other than we have the technology, you get friction. So if people don't want to use your systems, and if your systems are a mound of compromises, you're not going to realise the value. And the business case proposition becomes harder and harder and harder to realise, and the solution is to put more and more money into new things rather than paying down our technical and our process debt. So my wish... Do you want me to...
No. I was just thinking about you saying, because that is really interesting. No, go ahead.
So my wish is usability.
Right.
CLASS is an international organisation that looks at the usability of clinical systems. The top-ranked and the bottom-ranked hospital computer systems come from the same supplier. The difference is how they are configured to suit the user's need and how people are trained and taught to use these things. Healthcare is complicated. If you look in the plane, the next time you go on holiday, look in the cockpit of an A380 and it's got loads of buttons. It's really complicated. They train and they retrain. We do not do this. We instead expect people who use these tools to compromise. At the risk of going over my time...
No, this is good stuff. I'd stop you if you were bored.
All right, fantastic. I'm going to give people a kind of a thought experiment to take away. If you're a fancy London sort and you've got an overhead rain shower, clock out for a minute. But if you're a salt of the earth northerner like me, and you've got a shower on your wall, okay? Next time you get in the shower, start showering and then turn around, okay? I've realised this. I stand facing the water and my wife stands with her back. We both end up clean. But if I try and shower like she does, it feels wrong.
Right.
If you think of the neurosurgeon planning his operation with that little bit of inconvenience and friction, do you want that? I wouldn't. So make the systems work for people.
Right. Well, that was quite a gripping visual image that I. So I think we'll move.
I've got my trunks on.
We'll move swiftly on. Yeah. Okay. Fine. Yeah, Anca.
I was actually going to build on what Jim here has said.
No, naked.
And too boring, so I thought. No, but honestly, I wanted to respectfully disagree with Teus here. First, because I had the feeling he mentioned first off that technology is the problem, technology is the issue. And I just wanted to say, I feel your pain. I have been a frontline worker during the pandemic and an ISO auditor in the hospital. So I definitely felt all these things, working also in academia. I was completely on your side of the table. And then turning around into the policy part, I feel like the policy is the problem. I feel like there's a lot of technology out there. I feel like there's a lot of data out there. I feel like technology is moving at lightning speed. We're just too retrospective in healthcare still, and the bridge between policy and practice is still to be built. And I like the fact that you mentioned that there's also a process gap. And I wanted to emphasize on that I think that, as I said previously, just bringing another app to the table in a hospital won't change much. If we're not working on redesigning workflows and processes before we're putting the first stone, the cornerstone to build the app, and if we're not doing that with the clinicians side by side, we're not going to get anywhere. So,
and even if you do it with the clinicians, they might not want to change anyway.
Maybe just to conclude on that, I really think that if we're adding an extra burden on the workflows and the tasks on the clinicians, we're just adding extra layers in healthcare services that are not needed. If we're adding tech, we're just by saying we're creating something innovative, it doesn't really mean we're doing it. The answer is in building together and including the patient and the clinician at the point of care. And when we talk about startups, and maybe I'm inviting the conversation to continue on the same way, and the good use cases that there are in health tech in general are those that have been embedded early on in the process using real world data, using real clinical processes, and putting the patient and the clinician in the center of the technology when it's being developed. Only by doing that, we're able to relieve some of the burden of the health services on the patient side, but also on the clinician side, which we tend to overlook sometimes.
Estia, vision for the future, impediments, and then maybe if you want to reflect on anything that anyone said.
Yeah, absolutely. So I just want to pick up on what you said around policy. I think one piece we're really excited about is in the NHS's long-term plan, there's a lot of talk around rules-based pathways, innovator passports, which we're really excited about. I agree with you that there are many solutions on the market that have gone through regulatory pathways that are approved, that are safe. And the problem is getting them from startup to scale-up phase to deliver the ROI that we're all looking for. So I completely agree with you on the policy side. My wish is going back to a point that you raised earlier, and we call this the consumerization of health. But what it tries to get to is there are so many industries out there that have incredible data on you as a consumer, whether that is banking, whether that is your shopping habits, and that same data exists around your health journey. Typically, this data exists before you enter the health system. Of course, it's going to be more on that preventative side, but we see a huge opportunity in linking that data into the health service so that once you go to your GP, you are able to give an informed view of what you're feeling, and that data should not be belittled. I think we really encourage consumers and patients to be empowered by that data. So my one wish is really for that consumerization of health to be linked between consumer and healthcare services.
That would be great. So my iPhone would talk to my doctor.
Exactly.
Right. Okay. Chris, what do you think?
Well, I agree with that. But I think that on top, to add to that, I would say that there's the specific thing would be behaviour. And I think that the behaviour shift needs to go from the paternalistic system to what the Mayo Clinic coined, the patient will see you now. And it's only by changing that that agency and using technology to do that things will shift. Jim mentioned before, so I'm a clinician by background, and I've spent the last 30 years going with friends and family to clinic appointments, into hospital, accompanying them in all sorts of occasions. And the reason why I do that is because I have confidence in the healthcare setting. I have some knowledge, even if it's not my specialism, whoever I'm accompanying. And I have high levels of agency. So the clinician, Teo was saying about the, it's that interaction between the two. If I'm in the room with my parents, my friend or whoever, that consultation's better because there's more equality. And that makes the whole system more efficient. The patient goes away more empowered. The healthcare profession has an easier job. So we have to shift that behaviour from this low agency, doctor knows best, that's paternalistic, 2,000 years old, to giving that agency into the population, citizens before they become unwell, or patients when they become well, because unequivocally, expert patients stay well and use the health system less often, unequivocally. And technology is allowing us to be able to do that.
But I mean, what percentage of the population do you think want to be empowered, engaged patients? I mean, if that's 80%, then maybe sure, you're right. But what if it's 30%? What if it's 20%? What if the rest of them actually probably don't want to be thinking about their health and don't want to have the responsibility?
Yeah, so that's a really interesting conundrum, and this is why it's not really so much always about the technology. Technology is a part of it, but it's also behaviour and culture, and it's about creating that behaviour change, the motivation, the capability, and the opportunity for patients to be able to look after their health. And there are many people that will say that there are certain groups, socially deprived, young men or men who don't utilise the health system so often. But actually, you've got to understand why that might be. And that's sometimes because of confidence. So where we deploy our services, actually, the social deprivation and uptake is no less than those from, if you like, the worried well. And I think that's because there are patients in those groups who don't like going into an unusual environment like the health system. And actually, they're able to access healthcare in a way that they feel more comfortable, which is not going through the doors into a big white hospital and being overwhelmed. So I think that we just got to sort of not make assumptions and work on the behavioural side of things.
So can I ask all of you? I think personally, if I hear you, I don't necessarily disagree with any of it. I agree that my example of a patient and a professional is actually a process debt, I think. So, and then there's a usability gap, and I think technology is part of that, and organization is part of that as well, and the paternalistic part of that as well. So it makes much more sense to do it all together, right? Because either one of them will fail because all the other ones, because we're all right, because the other one, it's not just one impediment, we need all of them to tackle them together and redesign it in a new way. And I think that would be feasible. And then there is a limit with technology, there is a limit with organization, and that's prohibiting us from becoming less paternalistic, having the right process, because we as doctors and nurses, we've run out of tools. We don't know how to organize our healthcare any better anymore. And basically, we need to really fix this as a system, because I don't think that either of these solutions will work.
I mean, that's kind of the nub of the problem, isn't it? Is like, how do we change all of these things at once? I mean, the government here has just announced this new online hospital. I mean, is that really the only way we can do this? Is sort of like, just start something completely new, because we can't redesign what we've got. It's just difficult.
But I also would agree with Chris that, with Jim, my bad, that we cannot do it all at once, because then basically his point of starting from where we are is lost. So I think it needs to be small, but it needs to happen fast, and that's that's the real big challenge.
Does anyone want to respond to this?
So sorry, I was looking that way. I'm not speaking over it.
Go for it, Jim.
So there's a concept of systems. So a simple system is something that's easy to do and repeatable. Make a sandwich. Follow the instructions, we'll get the same sandwich. A complicated system is building a car. Follow the instructions, you'll get a car. Healthcare is a complex, adaptive system. Okay, so it depends on people, and people will have different views, decision-making, and approaches at given points. People will interact with each other, which amplifies that, and as a result, you have emergent properties. You put the same input, and you will not always get the same output. And efficiency and productivity, which cause burden, are output metrics. So if we have a complex system and we're looking for single interventions to cause change, I think we run the risk of failing. I'm going to do a Greater Manchester plug, kind of aligned to some of the things that Chris was saying. We're a prevention demonstrator site. So we're bringing together health and the mayoral authority, housing, education, all of these other bits of our system. We're promoting activity, we're promoting people into work, and I think that's the wrapper that starts to imagine healthcare in a different way. Healthcare is part of the solution, and I think we will fail if we believe healthcare and health services are the sole solution. We've got to work with other people.
Estia, I'm interested in what kind of health innovations you look to fund and why, and kind of like what you see on the horizon is something that is going to be useful to healthcare systems and why in terms of efficiency and burden. Yeah,
absolutely. And just before I do that, I just want to signpost an experiment that is trying to rip out the system itself. So there's a fund in the US called General Catalyst, if you have heard of that. But they've actually bought a hospital and are going to try to redesign the entire system and make it AI first, and create a new ERP system, plug in some of their portfolio companies. I don't know the outcome of that yet, but I think that's a really interesting project around how could we recreate healthcare and what a hospital looks like from day one. So I think that's something to look out for. And then in terms of what we're looking to back, I'd expand a little bit on the company we mentioned at the start. So we are looking to fund pathway changes. So again, the physiotherapy company I mentioned, they are able to deliver a 6-month physiotherapy pathway for less than the cost of a single private physiotherapy session. So again, it's like how does technology actually reduce the cost to serve over the long term? And I think physiotherapy is one example, but there are loads of others. Whether that's ADHD, some simple cases of mental health as well. And then in the medium term, I think the piece I'm really excited about is how do we start to think about kind of biomarkers we haven't looked at in the past and using that to kind of augment our understanding of health. So we're working with one company that's using menstrual fluid to see if they can stratify endometriosis and a couple other inflammatory diseases. But that is much more of a 5+ year vision. And the really exciting piece around there is nobody's ever looked at menstrual fluids. Can we start to think about how we can better understand inflammation as a result? So yeah, short term, it's technology and access. Medium term, it's novel biomarkers that haven't been looked at before.
And that physiotherapy, correct me if I'm wrong, they're completely AI generated physiotherapists.
So pathway is, I call my GP, I have back pain. About a third of GP appointments are back pain related. Typically, you then get put on a wait list, and then you're told that you have a slot, next week, Tuesday at 10 a.m. What happens now is you call your GP, you then get funneled into a triage system, typically on the phone. 97% of people pass that triage. You get told to download an app, and then you go through some really smart computer vision about how your body moves, so that if you're 60+ or 20, you don't get the same exercises, and you get put on a 6-month digital pathway. So you're working with your phone, and a clinician is obviously reviewing, your exercises over time. And then at the end, you 86% have symptom improvements, which is.
And you must be fairly confident that people will accept an AI physician, physiotherapist, right?
Yes.
Okay, that's interesting.
So,
Now-
so they collect the data on this. So 60% of people actually, to your point, prefer an AI physiotherapist because they feel less judged by an AI than a doctor. So I think there's a real point around, again, access. Like people want to have somebody that really listens to them and have personalized care.
That is a real shocker. And also, I mean, I've covered stories in this area before, and often you find there are certain areas of medicine where non-humans are preferred, like sexual health and things like that. Now, I'm just going to warn you all, okay? I'm going to ask Jim one more question in the panel briefly, and then I'm going to open it out to questions, and I expect questions, okay? So be ready. Jim, Teus, you were listening to Estia there about the innovations that they're thinking of, well, they are funding and things like that. How do you think about, from the other end of the spectrum, are these the sort of innovations that you would pick out as being things that would be useful for your health systems?
So musculoskeletal services are pressured. Okay, it's a great space to be in. Absolutely. You know, we need solutions there.
But like mental health, for example, maybe, that's an additive cost. Maybe the NHS is just like, nah, we don't need to bother about it because, the standards are so low. Why would we pay for this?
So if we want to describe the value, and in essence, what you're saying is, how do we decide to invest?
Right.
That's the real question. So what do we look for? We look for the clinical evidence base. So that needs to be generated so we know we can commission a service that's safe. Where the NHS is weak and needs to develop is its approach to healthcare economics. So you can talk about the cost of a physiotherapist or a session there, but you've got to think about the broader societal benefits, getting people into work.
Right.
There is huge value there and all the associated stuff that follows. So at the moment, I think we would look at this on does it fit into a pathway? Can we access it? And does it give us an ROI? We need to think more intelligently about the system value.
Societal returns.
That's the word I was looking for.
Do you have any thoughts about these innovations with this?
So I think Jim is actually really right that we need to see the entire impact on the society. Then again, and we were discussing that earlier, I think a lot of the examples like the biomarkers, I've seen that quite a bit throughout my life. Also, the predictive analytics, have been doing that for 20 years. And there's a new predictive analytics tool published every 20 minutes, you know that? And none of them make it into healthcare. So really, we need that. Those technologies are very specific, and we need something that solves that specificity. We need bigger things because you cannot fund every single pathway and every single thing we need to develop that. And I think so yes, these are good innovations, but they're not the key to solving the problem that we're addressing, I think.
Okay, good. That's a good answer. Okay, questions? Anyone? Lovely. Lots of questions. You're very good. Very good. You're 10 out of 10, all of
They're
you.
scared.
They're scared of me. I'm sorry. I'm such a bossy boiler. Go ahead and introduce yourself, please.
Hi there. Can you hear me? Hi there. My name's Bash Bhattacharya. I'm a consultant radiologist in North East London, AI lead for BHRUT. It's just a question about predictive analytics AIs that were mentioned, because that's the thing that's of growing interest in the NHS and healthcare. Recently, I think it was a Delphi model that got published recently showing about it could predict different risk factors. We've got the Foresight project, and they look like it can predict healthcare issues and allow early intervention. But isn't there an issue with misuse? For example, with the Navi Health AI tool that's currently got United Healthcare in trouble, where they use it as a way of judging people's risk factors, having their healthcare mandated by that. But on the other hand, shouldn't we be more mandatory and dystopian? Because fundamentally in NHS, we have to control budgets. And shouldn't we use that to try and prevent overuse? Because it's just something that I do see both the use and the disuse for. I don't know if anyone's got any thoughts on that.
Wow, that's a big question. Does anyone want to take that?
All eyes on me. The mic is gone.
It's a question about the ethics of predictive.
I was like,
right, isn't it?
What was the question?
Well, it's about ethics and how you wield these predictive tools and whether you can kind of, use it to predict behavior that you don't want, not just in patients. Is that right?
I think it's about whether it can overly control people and take away their autonomy.
Autonomy.
In the public healthcare system, should we do that? Because we are really about controlling
their autonomy.
The question would be, where should we start?
Can you give me an example about how predictive healthcare might unfairly control someone's autonomy.
So, for example, we could be in a situation where, because we see that all the time, for example, with GLP inhibitors,
Yep.
you have to have a BMI of, I believe, over 40. And I've seen other issues in which you've had, for example, immunotherapy for asthma, and I've got relatives who've been put onto it, and you see the actual indications for it. They're not in the literature. They've been different things have been added onto it as a control mechanism for rationing. And I think if you have those analytics, that's what it could end up being, where you have them as a control mechanism for patients.
So you're gonna base it. Well, I mean, I don't know.
I think the question is obviously complex, but the short answer would be regulation.
Yeah.
From where I see it, and you're probably familiar with these new environments, the same way as we were using hackathons before the pandemic and right after. There was this huge surge of creating healthcare innovation through hackathons. But when we're talking about AI and the ethical use of data, patient data, sensitive data, and so on, back to your point, there's these regulatory sandboxes that we could refer to where luckily all the stakeholders are brought in the same controlled environment. And I probably don't need to get into more details of how the regulatory sandboxes work, but that would be a way to provide in a controlled environment that not only that the regulation is embedded early on in the process of the technology development, but also that it can be easily adopted on both sides. And by that, I mean the technology can adapt to the regulatory pathway, should have not done so yet, and the other way around. The regulation can actually fine-tune all kind of loose ends that have not been pinpointed yet.
I'll take another question, and I'll also answer yours. I think it's also a societal question as well, and you need to look to Genomic England. When they introduced newborn screening, they consulted people. They said, what do you want to test for? So those kind of questions about what you should predict and what you shouldn't do, that's the kind of society question you have to ask. Gentleman there, and then I'll take that lady down there after that as well.
Being an older member of society and having lots of friends who are also in that category, very close to like health services.
Introduce yourself, please, sir.
Oh, yes, sorry. Roger from Business Solutions Company. Now, the big move to technology and everywhere companies all switching to that sort of area, it's creating a situation where those that can understand it, work with it and use it are getting healthcare, and those that find it much more difficult and dependent on old technology, old approaches of healthcare, isn't the health system at the moment creating a category of people that it's helping and another category that it is not?
Left behind. Okay, can you take the question from the lady at the front as well? So we'll take two questions at once. Thank you.
Hi, I'm Abigail Hodder. I'm an editor at Future Medicine. I wanted to highlight the reduction in the healthcare burden that is really important for clinicians, but actually several studies highlight that doctors are actually more burnt out after using AI, perhaps because there's such a volume of patients that they're getting through cases a bit quicker, but there's still the same volume. How can we mitigate this burnout with AI? How can we ensure that clinicians are properly protected and actually want to stay in the profession? Because a risk now is that a lot of doctors want to leave the profession, especially with the age of tech. They're moving towards tech startups rather than staying with the NHS. And with the recruitment freeze, that's obviously worsening things. So how can we ensure that we maintain the workforce?
Okay, great. So what I'm going to ask you to do is each of you is going to have 30 seconds to sum up, and you're going to answer either one of those two questions, okay? So haves and have-nots and burnouts. Teus.
I think you can answer both of them. I think I would say that both of them are an example of how we're not able to deal with shifting context. AI is not able to deal with shifting context. We can have a lot of the debate after this. My 30 seconds are gone. But I think it's also a shifting context between people, and current systems and organizations don't allow us to make that distinction. So I think it's all about being able to better shift context.
Jim.
Everything's complicated. So, but that's wonderful that the questions and the discussion embrace that. The idea that healthcare is simple and a tool will fix things without creating greater inequalities, without having impacts on staff, is wrong. The conversation has moved forward nationally and internationally to say these are complex issues. We need to think about the people and the processes and then the technology. It's a fudge.
Anca, thank you, Jim.
Thank you, Jim.
You're welcome, Anca.
Took the words. No, but also trying to reply to both of you in the same answer. I echo what both of you are experiencing, probably as a professional and not just an editor, but given the background and as a society and a patient, right? I always like to mention this in panels and say we're all patients. But we tend to forget that when we sit on these chairs, when we sit on the other side, then we realize this thing. But what I think where hope lies these days is that AI and the technology will lay the grounds for automation to the extent that it will not add an additional burden to the clinicians, but free up their time so that they can actually take care of the patients. And now back to the intergenerational gap. We can only try to work from a policy standpoint and find means and ways to work on the implementation part, not to widen these gaps. We're well aware of the risks and challenges, but I think that by freeing up the clinicians' time, we will manage to address also the not just let's just say elder populations, but also the gap that the technology might widen.
Estia.
So 2 really good points. I'm not going to pretend to be a clinician. I think I'm coming at it from a venture perspective. I think to reframe both of them slightly, I think we also need to think about the cost of inaction. Like what happens if we don't actually try to progress and try to get everything right on day one? Like, yes, there are going to be mistakes. Yes, there are going to be problems. No one can launch, 100% efficacious service on day one. But if we don't do that, then the system is going to break. And so I think as a society, we need to be comfortable that there's going to be some level of growing pains and manage those really well, whether that's a sandbox or something else. But like something needs to happen. And so I think those are 2 really important things we'll need to think about. But change is on its way, and we need to think about how to make it inclusive. But I would just try to think of it as like inaction has a cost as well.
Chris, one very quick final thought.
Yeah, well, I think that all sectors need to be catered for who find it difficult to access digitalisation, and it shouldn't be a reason not to bring that in, but they do need to be catered for within that process. Absolutely.
Right, well, I hope you'll agree with me. I thought they were great. Okay, so will you please give them a round of applause?
You too.
No, but I thought you were awesome. You're all brilliant.